Good afternoon, everybody. It's a lunch symposium, and it's always a pleasure to listen to Tamanas Chaudhury. He's an excellent orator, and even better than his oration are the surgery that he does. And in Kolkata, he needs, not what Kolkata, I would say in Eastern India, he needs no introduction. Tamanas has been very active in ASI, in Amasi, he's been Amasi president, and council member for ASI, and a brilliant surgeon. Tamanas, all yours.
Thank you, Chairman sir. Before I talk, I must introduce our chairpersons. Dr. P. Senthilnathan is a hepatobiliary surgeon of JM Hospital, Chennai. I think he does not require more introductions. He is one of the renowned hepatobiliary surgeon of our country. Dr. Prabal Niyogi, he is from Allahabad. He is a professor of surgery. And one more introduction I want to say in this hall, that everybody should support him. He is the president contestant ASI for this year. So we must support him. And Dr. Anandya Acharya, professor of surgery, Santiniketan Medical College at present. And now he was a professor of surgery in IPJMIA. And he welcome Somnathda. Anandya is one of the good surgeon I have seen since we did PG together. Anandya was quite senior to us. So even being we are batchmates, we used to learn from him because he was senior in our batch. So we did MS in same batch, but Anandya was quite senior. So he has a lot of experience that time. So being batchmate, we used to learn from Anandya from those days. So welcome all chairperson and my friends. This is a lunch symposium. We just talk on something about the mace and what mace nowadays we are using. So if we look back, if we don't see the history of hernia surgery, we cannot understand what exactly, why this mace and what kind of mace really coming up. So this hernia history since 400 BC. So it's a long journey of hernia for evolutions. These are the common abdominal wall hernias that we all know. I am not talking about now. We are not thinking about inguinal, femoral or these hernias. We talk about groin hernias. This groin hernias concept basically it's a evolution. We understand it is a area where a lot of particularly the frucet goes for myopectoral orifices. So these evolutions from Susruta, the almost 100 procedures came up. If we go one by one, we can understand why these evolutions. And the topmost priority for any hernia evolution is to prevent recurrence. It is target to make a zero recurrence, because if we operate somebody and the patient come back with the same hernia, it is not the 100% failure, rather it is more complicated because the recurrent hernia will be more complicated. So the target for any hernia repair is zero recurrence. So now the era of prosthesis came up, and these era of prosthesis came up from since 1976, when there is a tension-free hernia repair concept came up, and instead of and this placement of a prosthetic mesh. Earlier there the tissue, some fascia lata, these are all tried, but those are not that good enough to protect recurrence. But this prosthetic material as a mesh which is applied, go for a licensed and repair, that is one of the, and then concept of the same mesh, instead of putting anterior, it is go to the posterior for stopa or naihas. These are all of that mesh. Then once a time has come, now I can see that gentleman Shomitroda, he was promoting this Prolin hernia system when I was just pass out as a PG, and he made an arrangement to visit US hernia hospital to see these procedures. I was very unfortunate because my passport was not 6 months valid that time, so I cannot travel. But some of my friends visit there and they saw how this Prolin hernia system works. And they came back and learned this procedure. And Dr. Bhartiya was there. We all were, myself, Dr. Bhartiya, Dr. Sanjay Deboksi, all were there in a same queue for visa in US Embassy. But they said you are not eligible because your passport was not 6 months valid. That knowledge was not there. But for your understanding, whenever you plan for any foreign visit, check your passport first, it must be 6 months valid minimum. This is one message I learned on that day. But anyway, the learning not stop. That time it was very promising procedures. But over a period of time, I don't know how many of us is doing any Prolin hernia system. I think hardly anybody is doing that. So as time goes on, this laparoscopy came up. So comprising from anterior placement of mace to posterior retroperitoneal mace placement is these concept when people accept. So these laparoscopic hernioplasty came up. And these hernioplasty, laparoscopic hernioplasty, because of retrorectus mace placement. So now it's almost TAP or TEP. These are the most two standard procedures. Some of us sometimes we require to do E-TAP, but basically TAPP or TAPE is a standard procedures of today. Why this shift? Basically the same again I repeat, these concept of myopectoral orifice from inguinal hernia to groin hernia, that is the concept. So we have to cover all myopectoral orifices by placing one shot, one mace, so that we can cover all these. So these laparoscopic hernia repair became more popular instead of only tension-free repair of Lichtenstein repair. So if we look, these are the look for a ideal prosthesis is going on. It should be a lot of biomaterials was used, that synthetic materials, polyester, polypropylene, expanded polytetrafluoride, EPTFE, a lot of materials came up, but none of them can fulfill all the criteria for ideal mesh. Ideal mesh must be chemically inert, it can be fabricable, it should not be allergic, and it must be infection resistant. And as such, we are still looking for an ideal mesh. These are different kind of mesh which are available in market. But what still we are happy with some mesh, in particularly inguinal hernia repairs. That is one of the very popular mesh is polypropylene mesh. This chemical is very nice and lightweight, medium weight, normal polypropylene mesh. That are different options are there. But what we come up with this kind of mesh when we choose, we must keep in mind that mesh itself has some problems. And we cannot avoid putting a mesh in hernia repairs, but we must be very careful. So there should not be any chance of, because these all mesh can shrinkage, so proper size should be chosen. This is one of the most important. Proper dissection is one of the important aspect. So wide coverage is important. Minimum 5 centimeter from the defect. It's a standard. It can dislocate. If we do not put it proper place, if we cannot fix it, it can dislocate, and definitely sometimes it can restrict mobility. In some patients may have pain. A mesh can get infected if we do not take that care of managing that sterility in hernia repair. One of the dreaded complications of hernia repair of mesh placement is infection. To remove one infected mesh is very challenging. So we must be very careful when we do any hernia surgery with applying a mesh. Mesh seroma is another, because of tissue inflammation, this seroma can happen, but most of the time we can manage it by aspiration and others. If we look the standard mesh preparation from a 15 centimeter, 15 by 15 centimeter mesh, we cut the lateral surfaces, two edges, because lateral is slightly lower space. Medially we must cut to accommodate the prostate in that areas, in bladder areas. But we have to design, we have to roll it, then put it inside. But now in an era where somebody is doing my job at the table in a prefixed, pre-sized mesh, which is anatomically can accommodate on that areas. That's why these concept of anatomical mesh came up. So this is the same polypropylene mesh which is designed and exactly by sizing. It is the standard two sizes were available, 17 by 12 and 10 by 15. Out of these are transparent. We can see the structures. These are all good for the polypropylene mesh. And if we look in a standard polypropylene mesh, cut into the size and put it, normally we handle half of the mesh at a time. We suture it, roll for a half. Some people manage hold the mesh together, but there is no as such marking, so we have to do the marking either inferior-medial part, then we roll it out, and then we fix it in the hernia defect to cover. This is all good to put this mesh and fix it at least 3 to 4 points. But as time goes on, if we have these options, same polypropylene mesh in an anatomical size. What we did, the moment we put the mesh, probably you can see it's opened up easily, and it can take the shape of the groin areas very comfortably. And that's the advantage of these anatomical mesh. We do not require to roll up or half that kind of thing. We can manage the mesh at a time and it's comfortably cover all the myopectoral orifices. I am just skipping this video, and this is another, but the interesting part for these both anatomical mesh is it very specified for either right side or left side. It is not like 15 by 15 mesh which can be cut and we can design either for right side or left side. So whenever we are in theater, we must be checked. If it is a right side hernia, we must be look for a right side hernia mesh and the proper size. If we wish to plate it 12 by 17, either that 12 by 17 or by 15 by 10, that must be there. So we must be very careful. If the person is adult, tall, we must be look for a 17 by 12 mesh. In TEP also these mesh can be managed very comfortably, and one point fixation is good enough. And in TEP particularly, as our space is minimum, there is no as such bigger space like a TAPP. So what happened, we can manage this mesh very comfortably in TEP as well in TAPP. The landmarks should be, but the mesh basically not the only thing which prevents recurrence. Avoid proper dissections, proper placement of the mesh, that is too important. It should not be too medial or too lateral. The advantage of this anatomical mesh in that point is that it takes the anatomical shape. The way we put it, it will take exactly the area where the cord structures and others can be covered properly, and we can take it. Even in other left side TEP also we can do it. So all sides, I am just skipping this video so that we can understand that the anatomical mesh is one of the which make easier the surgeon's life. Friends, hernia surgery is one of the most challenging surgery because we have to understand the anatomy, and we must keep in mind that we must have some amount of suturing skill, particularly if we do. Now we are fixing this mesh with tackers, but it can be done with sutures, one polypropylene sutures. I know Dr. Senthilnathan never put any tackers, they just put a suture for fixing the mesh. Some people are fixing the mesh with glue, so that options are there, but definitely suture is definitely low cost and it's a good one to prevent it. So as my topic is the future of the anatomical mesh, no one can see the future, but what we can predict, it is our actions today which makes us for tomorrow. And what we are now is the result of our past actions. So friends, ultimately what we do today, what we learn today, that will make us for tomorrow. Thank you very much for your patient hearing. Thank you. Thank you.
Thank you, Tamanas, for a lovely lecture. Any questions from the house? Yes, Somnatha.
Mic on, please.
Have done the same thing, but not stitching, not tagger, nothing of this sort. They have only placed the mesh. He is very famous in Maharashtra doing this sort of hernia surgery. Only you just place the mesh in such a way that it will, they are of its own. So anatomy is such a thing. If you can place correctly, it will take up. Is it true or not? People are already stitching or taggered or so many things, fixing. But without fixing, it can be or not.
There are large studies on this.
Yes.
There have been Italian studies which say that you don't need any tacker or fixation devices. But it's been proved otherwise that if you do not put any fixation device, there is a mesh transplantation or movement. So it is better to fix it with anything, suture, tacker or glue, whatever, as Dr. Tamanas rightly said. I have no experience, Tamanas, with this mesh. What is the material? Is it the polypropylene, same material?
Exactly, it is a polypropylene.
Right.
So
and does it help take the contour of that
area?
Area?
It takes the contour of the groin areas.
Right. And what is the cost of this?
It's definitely slightly higher cost. Exact amount I don't know, but you know the hospital do these arrangements. So exact amount I don't know, but stamp price I can ask a Medtronic person to say that stamp price.
Excellent videos, sir. At the end of the dissection, I was looking at all the videos. We have seen the bloodless dissection. That is far more important, whether it is in TEP or TAP. It's the fine dissection, I believe. The surgeon's finesse comes with the hernia surgery. So excellent. Thanks for showing the excellent video. Again, I have the same doubt. If the contour of the abdomen doesn't fit into either of the two sizes which you have mentioned, the 18 centimeter or the
1712 and 1510.
Yeah, what will you do? Will you try to accommodate or any will there be any spikes in the mesh that will help it to fix it onto the intra-abdominal wall?
No. In these anatomical mesh do not have any spikes. It is not a self-fixating mesh. There is some mesh available which are self-fixating. It is not that. It's really challenging if it does not fit in the. So in that case, particularly, we have to put instead of in TEP, instead of one fixation, we can put two more fixation in above the iliopubic tract, or that is the only option we left to give the shape of the area.
But otherwise, excellent videos, sir.
Thanks. Thank you so much. So now I request my next speaker, Dr. Ramdeep Roy. Dr. Ramdeep, take your podium.
Is a transplant surgeon at present, attached to Apollo Hospital, Calcutta. He did his undergraduate training and postgraduate training from Calcutta, IPGMER and Medical College, and then went in for training for laparoscopic, transplant surgery. Worked for some time in Medanta Hospital, and then he has come down to Calcutta as a transplant surgeon. Now working in Apollo Hospital.
Thank you very much. Small correction, I did not work at Medanta, but at Apollo Hospital, Delhi, and then Artemis, Gurgaon. So this is an industry-sponsored session, sponsored by J&J. So it is largely, the slides are, you have to keep that in mind, but it is more of an experience sharing because they have the hemostatic products, the particular product which we used, and the technique of usage rather than the data and the evidence in favor of effectiveness. So if we manage to create okay, so I have to click on that every time. So sometimes we manage to make nice injuries like the one here. We've managed to injure the right hepatic artery in a Whipple's, and I don't think hemostatic adjunct is going to work there. Sometimes we have bleeding, which is venous, which is brisk, as in a living donor. You see that the liver is being transected, and we would rather just apply a gauge piece, pressure, that's compression, and wait for the bleeding to be controlled rather than using any adjuncts. So that's brisk venous bleeding. And sometimes we have this kind of a bleed. This is a liver resection which was done for colorectal mets. A left hepatectomy was done, and there were a few mets on the right side as well, and this is one such extension, and you can see that there's some bleeding from there. So those are what we are looking at. Now, uncontrolled surgical bleeding adversely affects patient outcomes, hospital cost and resources, I know. This is some literature. Sometimes data can be presented in very interesting ways. So this is, some series says that 32 to 68% of cases in open procedures experience major uncontrolled bleeding events. I don't think so. I don't agree with that at all. But then this is what data and statistics sometimes can be, you know, there's lies, more lies in statistics. But yeah, we understand that bleeding sometimes can be challenging, and definitely challenging and uncontrolled bleeding during surgery has high morbidity and even mortality, and definitely lots of resources are utilized. And the new normal is that we very often operate on patients who are above 80 years of age, who have comorbidities, who have increased bleeding risks. Sometimes you have to operate in emergencies where even the medicines which need to be stopped for a certain duration, they also can't be stopped. So we can have different kinds of bleed, capillary, venous, or arterial. And whenever we have arterial, obviously the primary methods are going to work. And in others also, it's primary methods plus adjunctive. It's never a substitute really. We have to look at the intensity, we have to visualize, we have to able to visualize the bleeding source, we have to keep in mind the tissue surface, friability, etc. And access is very, very, very important. And there are primary methods and there are adjunctive methods. Again, I'll not go into the details. So, the hemostatic cascade, there are many places in which these can be targeted, and all the potential steps along the cascade can be targeted by different mechanisms. And there are products commercially available of different companies which target all these different steps and try to help in hemostasis to some extent possible in the OR. And depending on what is the situation, there are different products which surgeons use. I think in most cases, surgeons feel that the adjuncts don't work much, but at the same time, in desperate situations, surgeons do use these adjuncts, sometimes with good results, sometimes with bad results, but most often what happens is it's an equivocal kind of a situation. We don't really know what worked, but at the same time, there are different series which show that they have to some extent reduced the bleeding severity. So there are different products. Again, this being an industry-sponsored session, so these are the products, the different kinds of products that are available. And in particular, the newest thing on the block is we've all used Surgicel for a very long time. Again, effectiveness or not, we've all used it. And obviously, one of the problems with Surgicel, the sheet, is that it tends to fall off. The weight of the sheet itself sometimes tends to make it displaced, and which is logical. The logical extension, therefore, is the thing being used, being provided in a powder format. And unlike some other products where we had to prepare it in the operating room, the final bit, that doesn't need to be done here. So it's definitely easy to use, and it's again the same thing as the traditional Surgicel, the oxidized regenerated cellulose technology. The claim is that while the absorption time is 7 to 14 days, the time to hemostasis is 52% faster than their own traditional product, and it is ready to use. That's a very good advantage, and it is available both in a way that it can be used for open surgery as well as the long tip, flexible as well as rigid in laparoscopy, which is becoming the larger part of most practices. So this is the same venous bleed thing. So this was the bit of the bleed from that crater which we managed to create because of that additional tumor which we tried to take out, and this is the Surgicel powder being sprayed on. This being predominantly an experience sharing session as planned by the sponsors and the organizers. So here we just demonstrate how it is applied, because not everyone has had the opportunity of using it yet. So it's just the same Surgicel powder largely being sprayed, and then we wait. After having applied it, we wait. I forgot how long we are supposed to wait. 1 minute, okay. So 1 minute, we wait. We used it in this particular case, and then after that, you wash away the extra powder. Me being a surgeon, believing in primary methods more, I think I was a little over-aggressive in the saline flush. Maybe we can do it a little less aggressively as well. I reiterate, I don't know what worked. There was still some mild thing, nothing significant. that is the net result. And as surgeons, since there was some more powder left, even when the entire thing is done, we went on to do the other steps using a little bit more of the powder lying there. So effectiveness will come with more data, will come with more experience, but definitely it's easy to work with the powder form. So this is the main reason for the presentation today. Thank you so much.
Thank you. Thank you very much for this session. But it's an interesting thing. But I believe, as somebody said, the best hemostatic agent is the surgeon himself. So that's the last word. Thank you very much for your patient hearing.